So students, this is another, apart from the exercise of our last class, this is another abnormal state rather. It is not a normal physiological variation. That is the question of haemorrhage. Haemorrhage, or in layman's term it is bleeding. So what will happen to the cardiovascular system when there is hemorrhage? Now, as we understand, hemorrhage means loss of blood out of vascular system. Loss of blood out of vascular system when, due to any reason whatsoever, blood comes out of the vascular system, that is known as bleeding. So I told you blood remains the most dynamic component of extracellular fluid. It is residing inside the vessels, and inside the vessels it is moving here and there and everywhere throughout the body, reaching out each and every cells, tissues and organ of our body. And blood is assigned to kept inside the vessel. Now, due to any reason whatsoever, when the bleeding occurs, when the vascular wall is damaged, and bleeding occurs, suppose this is the vessel, and there is a damage in the vascular wall, and bleeding is taking place. So blood is coming out of the vessel. There will be net loss of vascular fluid. And the volume of fluid inside the intravascular space will be reduced. Now, our aim would be in coming half an hour or 40 minutes to understand what will be the consequence of this inadvertent, accidental reduction of intravascular fluid on our body, number one. And number two, how our body in general and cardiovascular system in particular respond to this inadvertent, accidental loss of intravascular fluid. And to understand that, we will also understand how, if the intravascular fluid volume is reduced, what will be the adverse consequence on our body? What may be the possible adverse consequence in our body? So, these are the three issues which I shall try to answer before you in as lucidly, as simply as possible. Now, whenever there is a net loss of intravascular fluid, what will happen? The intravascular pressure will tend to fall. So the blood pressure will tend to fall. I tell you, will tend to fall. Why I am using this tendency issue? Because our blood vessels are not a rigid vessel. Blood vessel is either an elastic vessel or a muscular vessel or a fibrous vessel or an exchange vessel, whatever. So blood vessel is a living pipeline. So it has also got certain ability to respond. So whenever we say that response to hemorrhage, we mean to say response to hemorrhage by the cardiovascular system, both heart as also the vessel. So, so this is the issue. This is the issue that both vessel and heart will respond and how they will respond. Now the problem is that if BP is fallen, there will be net fall of the perfusion pressure. If there is net fall of perfusion pressure and it is the pressure which is driving the flow, we time and again told you Q is equal to delta P by R, delta R. So flow is pressure gradient by resistance gradient. So resistance differential. So this is, if this is the thing and if this is the function of cardiovascular system. So in order to maintain the flow, pressure head is very vital. So if pressure head is fallen, the flow maintenance will not take place. Now try to understand the consequence first, then we shall try to understand the response. So what will be the consequence? So there is a loss of fluid from the vascular space, that means loss of blood from the vascular space, and the blood pressure will tend to fall. If blood pressure tends to fall, the peripheral flow will suffer. So body will not allow that. So if this is fallen, this will change. So inherent response what will be? So when blood pressure is fallen or already reduced, what will happen immediately? You all know, baroreceptor response. So blood pressure is fallen, baroreceptor at the carotid sinus and aortic arch, they will not stretch adequately, they will be less stretched, less stimulated, and baroreceptor is a negative feedback, so blood pressure will rise. So when blood pressure is fallen, purely due to baroreceptor mechanism, there will be two response. One will be the vascular constriction, number two will be increased heart rate and increased contractility. So whenever due to baroreceptor mediated action, due to fall in blood pressure via baroreceptor, there will be increased inotropism, there will be increased chronotropism, and there will be increased vasomotor tone or vascular vasoconstriction. So that will be the natural response, and it will take place immediately, within a second, within a few seconds it will be achieved. So whenever there is a little loss of blood, say 2% loss of blood, 3% loss of blood or 4% loss of blood, which happens quite frequently. Suppose we are fallen, there is a cut and there is a 200 ml of blood is lost, or somebody is suffering from hemorrhoids, piles, which we commonly know during there will be abnormal collaterals. So at the time of passage of stool, they lose blood, sometimes substantial amount of blood, 200 ml, 300 ml, 500 ml of blood or 400 ml of blood is lost, but that will not matter much because there is a full-fledged baroreceptor mechanism. So it is a baroreceptor mechanism. Whenever blood pressure is fallen, whenever the delta P is fallen, leading to tendency of derangement of the blood flow, immediately by three mechanism, by increased inotropism and chronotropism, that will be recovered, and by increased resistance also. So it will constrict and thereby it will maintain the pressure head. So ultimate aim is to maintain the pressure head. If pressure head is maintained, ultimately the flow will be maintained. Now suppose if blood loss remains sustained and persistent, a continuous blood is being lost, the loss of blood is not stopped, still sometimes the blood is getting lost, and from 2%, 3%, 4% it becomes say 10% or 8%. 10% means substantial amount of blood, nearly 500 to 600 ml of blood is lost. Now, if a substantial amount of blood is lost and if it is continue to come out of the vascular system, the delta P will seriously fall. Delta P will seriously fall, and baroreceptor mechanism will further act. Baroreceptor mechanism will further act, increase inotropism, increase chronotropism, and increase vasomotor tone or increase vasoconstriction. But again, there will be a upper limit of baroreceptor activity. If you remember my earlier diagram, once upon a time I had shown you a diagram that is the buffer nerve activity. When the blood pressure or mean blood pressure is gradually increasing, the baroreceptor afferent stimuli is also increasing, but at a particular point of time, there will be buffer nerve saturation. There will be buffer nerve saturation. So, if the pressure is falling too much, the opposite is also true. If the pressure is falling too much, a point of time will come, baroreceptor will fail to correct it. Because baroreceptor mediated blood pressure correction is nothing but an example of negative feedback, and every negative feedback or every biological regulation has got a range of operation, has got a specific range of operation. It will operate within that range, not beyond that, not below that. So if blood loss is too much, a substantial amount of blood is being lost, what will happen? Instead of negative feedback correction, the situation will become positive feedback. Instead of a negative feedback correction of blood pressure, situation will become positive feedback. That means instead of error correction of error, there will be perpetuation of error. So that is the danger of continuous and persistent bleeding. So whenever there is bleeding, as a physician, you must first stop the bleeding at any cost. And if the bleeding is stopped, you assess the amount of bleeding and then act accordingly. If it is a minimum amount, then body will take care of alone by rapid mechanism of baroreceptor mechanism, and also by mid-term and long-term certain other mechanism which I shall coming soon. So baroreceptor mechanism is the first attempt by means of which a mild hemorrhage leading to a mild or a moderate fall in perfusion pressure will be managed by increased positive inotropism, increased positive chronotropism, and increased vasomotor tone or vasoconstriction. And after a certain level, this will not serve the purpose, or rather, this will not act. Now, what will happen then? If our whole system entered into a positive feedback issue, what is positive feedback cycle, what will happen and how it will happen, try to understand that. So negative feedback is error correction. Negative feedback is error correction, and positive feedback is error perpetuation. So negative feedback is error correction and positive feedback is error perpetuation. Now let us see how this positive feedback mediated error perpetuation takes place. Now if the blood loss is too much, what will happen? Pressure will fall so much. The organs and system, tissues and cells will seriously suffer from hypoxia. So blood loss, if becomes to such an extent leading to such a fall in the perfusion pressure, there will be serious problem of supply to the peripheral tissue. So there will be a serious problem of supply to the peripheral tissue. And that situation is known as shock. Shock or circulatory shock. So that is known as shock or circulatory shock. This circulatory shock may be a kind of shock. What we are talking about is hypovolemic shock. So it is a hypovolemic shock. Hypovolemic shock means when blood volume is reduced. So when blood volume is reduced seriously, thereby it is failing to maintain the perfusion pressure, and thereby there is a serious problem of supply to the peripheral tissue, cell, tissue, organ, etc. Then what will happen? They will suffer from hypoxia. So when they will suffer from hypoxia, hypoxia means, as per definition, it is the lack of oxygen supply at the tissue level. When they will suffer from hypoxia, obviously, that hypoxia will stimulate chemoreceptor mechanism. Hypoxia, if it leads to hypoxemia, it will stimulate the chemoreceptor mechanism. And chemoreceptor system is an excitatory system that will tend to increase the cardiac contractility, that will tend to increase the cardiac chronotropic action, heart rate, etc. Thereby it will try to make over. But again, that may be insufficient if there is a continuous and persistent loss of blood, persistent loss of blood, and blood pressure remain persistently low. So this hypoxic chemoreceptor mediated action is also a drastic attempt to correct the issue. But if it also fails, so the shock will continue. And as it has produced hypoxia, that hypoxia will produce anaerobic metabolism, and that anaerobic metabolism will produce various anaerobic metabolite like lactic acid, like adenosine, like potassium, like carbon dioxide, etc. And these are all vasodilator. So anaerobic metabolites, which are all vasodilator, so they will form vasodilator metabolites. They will form vasodilator metabolites. They will form vasodilator metabolites. And all this hypoxia will lead to anaerobism. Anaerobism will lead to anaerobic metabolic byproduct accumulation, which are all vasodilator metabolites, which will lead to vasodilatation, and vasodilatation will lead to further fall in blood pressure. Further fall in blood pressure will lead to further fall in perfusion pressure. Further fall in perfusion pressure will lead to further enhancement or aggravation or deterioration of shock, which will lead to further anaerobism, further vasodilatation. So, once it will lead to production of tissue hypoxia, which is not rectifiable even by the chemoreceptor activity, it will enter into a positive feedback cycle or a vicious cycle, ashubha chakra, vicious cycle, and it will perpetuate the error. It will progress the error. It will deteriorate further and further. And that kind of shock is known as irreversible shock. That kind of shock is known as irreversible shock. So if the patient enters into that stage, it is very difficult to save the patient, because whole our own body will then act to irreversibly deteriorate the shock, irreversibly produce the catastrophe or devastation. So this is how the positive feedback section. But can't we do anything? So we can divide whole of this hypovolemic shock stage in 3 levels. First level is compensable shock or compensated shock. So first level of shock we can say, or first level of hemorrhagic response we can say that compensated. So first is compensated. Second, we can say the reversible. And third, we can say irreversible. So one is compensated means, say a 5% loss of blood, body can manage in its own. Body can manage in its own. How body can manage? First of all, by baroreceptor mechanism. It can immediately arrange. And there are other mechanisms. I shall tell about the other mechanism. So, first is body can manage in its own. Say around 5% loss of blood. 5% loss of blood. If it is say 10% loss of blood, then probably body by its own mechanism cannot arrange. Then you have to give some support. What are those support? You may need to infuse some fluid into the vascular system. Say normal saline, you give some fluid into the vascular system and thereby increase the intravascular volume. If the intravascular volume is increased, then what will happen? The perfusion pressure will be maintained. So some infusion, either a saline, 5% saline, or any such thing, or plasma, or even a whole blood. Whole blood may not be available every time. So you can give just normal saline, or plasma, or whole blood. If you give that, infuse that, and thereby expand the plasma, try to expand the plasma, try to maintain the plasma volume, or intravascular blood volume, the pressure head may be maintained. Or you can use some drugs also. But there are certain problem of using drugs. What drug you can use? You can use some excitatory stimulant like vasoconstrictors. But there are certain problem of using vasoconstrictors. What vasoconstrictors will do? Vasoconstrictors will cause vasoconstriction, no doubt, thereby reducing the delta R, thereby increasing the resistance, and increased resistance will decrease the flow. So that is the problem with vasoconstriction. So vasoconstriction, by constricting the vessels, you can in one way maintain the pressure head. Because constriction of vessel will reduce the vascular available space, and with the same volume of blood, pressure may be maintained. So by vasoconstriction, you can act in a way to maintain the pressure head, but at the same time, by increasing vasoconstriction and thereby decreasing the radius, Q may be compromised. So individual organ level flow may be compromised, and then that may deteriorate the situation, at least in the organ level. So it is difficult. Sometimes it is difficult. It requires a judicious approach to use vasoconstrictor. Rather, you can use vasodilator. If you use vasodilator, there are two advantages. Number one, it will increase the arc. It will increase the radius. And if it increases the radius, it will reduce the resistance. And if it reduces the resistance, the Q will increase. Blood flow will increase. At least in the organ level. So these are the advantage. Disadvantage is that if there is vasodilatation, already compromised vascular volume will be further reduced due to relative increase in the intravascular space. So that is a problem. So we need to have a judicious use of vasoconstrictor and vasodilator. There are protocol by which we use. So this is how we can manage the reversible shock. But suppose it becomes a 15% loss of blood or more than 15% loss of blood, then patient may enter into the irreversible stage. And once it enters into the irreversible stage, the error will be perpetuated. Production of organ level, tissue level hypoxia, hypoxic metabolite, further vasodilatation, further fall in pressure, further fall in perfusion pressure lead to further progress of the shock or deterioration of the shock. Not only that, when an individual organ suffer from hypoxia, they elaborate some toxic substance sometimes. I give you an example. One such substance is MDP, myocardial depression protein. It is secreted from pancreas and hypoxic pancreas. And hypoxic pancreas can secrete a substance known as myocardial depression protein, which will depress the myocardium, which will reduce the pumping action of myocardium, which will compromise the systolic function of ventricle, and that will deteriorate the situation. So there are many such substances which may be secreted from individual organ, and thereby it will further deteriorate the situation. So these are some of the aspects. So if there is hemorrhage, and this is how the hemorrhage are compensated. But I told you that apart from this neural reflex or baroreceptor reflex and to some extent chemoreceptor reflex, there are other way of compensation or reversal of the shock. What are they? Now those things, although not yet taught, but let me mention some of them. First of all, the capillary fluid shift. This thing is taught to you. Suppose this is a capillary. So this is the arteriolar end of capillary, this is the venular end of the capillary, and how capillary filtration is taking place, I have told you in detail. There are 4 Starling forces: PC, PI, Pi C, Pi I, capillary hydrostatic pressure, interstitial tissue hydrostatic pressure, capillary oncotic pressure, and interstitial tissue oncotic pressure. I have told you. Now suppose when there is fall in perfusion pressure. So normally what happens? The fluid is going out from the arteriolar end of the capillary with a pressure of plus 16 mm of mercury, and fluid is getting into the venular end of the capillary with a pressure end of minus 14 mm of mercury. I have discussed everything of it. So this is what is happening in normal situation. And it is the osmotic pressure is 25 mm of mercury which is holding the fluid in. Now, if due to any reason, if there is a loss of blood, when blood is lost, leading to fall in the perfusion pressure, and this fall in perfusion pressure will tend to reduce this pressure. What is the pressure here? Capillary hydrostatic pressure is 40 mm of mercury here in the arteriolar end of capillary and 10 mm of mercury in the venular end of the capillary. So this will fall. This will fall mainly. So 40 may be 30. Although 10 will not change much because 10 is already low. May change a little bit, but 40 will be reversed. So this capillary hydrostatic pressure at the arteriolar end will fall. As a result of which, in regular normal situation, there will be net capillary shift of fluid from capillary to the extra capillary space. Plus 16 minus 14. So capillary fluid is going out of the arteriolar end of the capillary with a net filtration pressure of plus 16 mm of mercury, and fluid is getting into the venular end of the capillary with a net filtration pressure of minus 40 mm of mercury. That thing becomes reversed. That means less amount of fluid will go out and relatively more amount of fluid will get in due to change in the hydrostatic pressure. So this hydrostatic pressure is reduced. It becomes from 40, it becomes 30, and if you just now calculate it, you will see that it will be nearly plus 12 and minus 14. So there will be net shift of tissue fluid into the vascular space. So this is known as capillary fluid shift. As a result of this capillary fluid shift, some amount of tissue fluid is relocated into the plasma. Thereby it will expand the plasma volume, albeit it will cause some amount of hemodilution because it is a plain fluid. So it will add up into the vascular fluid, thereby dilute the blood. Blood will be diluted. There will be hemodilution. But in spite of hemodilution, the vascular volume will be expanded and the perfusion pressure will tend to be maintained. So this is another way, another compensatory mechanism by means of which there is a net shift of fluid from the extravascular tissue space into the vascular space. So this is one way. There are many such other ways that, so when another way is called renal mechanism. Now renal mechanism has not yet taught, or endocrine system has not yet taught. I just tell you a few things about that. Just a few things. So renal mechanism, we know that if the perfusion pressure is reduced in the systemic circulation, the perfusion pressure to the individual organ will also be reduced. If the perfusion pressure in this individual organ is reduced, say as for example in kidney, if the blood flow or perfusion to the kidney is reduced, kidney will start secreting or increase secreting a hormone known as renin. So that renin, so a hormone will be secreted known as renin. That renin will produce a substance known as angiotensin 2. You will learn everything later. So this renin will lead to formation of angiotensin 2. And this angiotensin 2 will lead to formation or secretion of aldosterone. This is known as RAAS, renin angiotensin aldosterone system or RAS system. So renal hypoperfusion will lead to activation of the RAS. Renal hypoperfusion will lead to activation of the RAS, activation of the renin angiotensin aldosterone system. Now this angiotensin is a powerful vasoconstrictor. Angiotensin 2 is a powerful vasoconstrictor, thereby it will reduce the intravascular space and try to maintain the perfusion head. And aldosterone causes increased reabsorption of water and sodium in the kidney tubule, mainly in the distal tubule or distal nephron. Aldosterone will act, leading to increased absorption of sodium and increased absorption of water, and thereby will increase the plasma volume. So renal hypoperfusion leading to activation of RAS system, leading to increased vasoconstriction, angiotensin 2 mediated and aldosterone mediated increase in the plasma volume will tend to reverse, will tend to compensate this amount of hypovolemic shock. So all these are various mechanisms. Not only that, any shock or any injury, any hemorrhage will lead to increased sympathetic activity, and this increased sympathetic activity will cause increased secretion of adrenaline and noradrenaline. And this adrenaline and noradrenaline via its various adrenergic receptors like alpha 1, beta 1, etc. increase positive inotropism, vasoconstriction. All these things will be produced by adrenaline and noradrenaline as a result of increased sympathetic activity. But all this thing will happen within the range of mild to moderate hemorrhage. During which all these physiological mechanism, either alone or assisted by a doctor, by infusion of saline, giving certain drugs, is possibly happen. But if the bleeding continues, hemorrhage remains persistent, leading to more than 15% loss of valuable blood from our body, that may push the patient into the situation of irreversible shock. And once it enters into the irreversible shock, the whole kind of negative feedback regulation becomes positive feedback, and our body system will gradually deteriorate. So being a doctor in future life, when you practice your profession, it is very important to identify the stage of hypovolemic shock. It is very important, crucially important to identify the stage of shock and thereby to use appropriate therapeutic treatment so that we can save the patient. So this is about this is something about the physiology or rather pathophysiology of shock. How the loss of blood from our vascular system leads to reduction in perfusion pressure, leads to tendency of development of hypoxia, and thereby all possible catastrophe, and how our body system by its own mechanism, by rapidly acting neural mechanism via baroreceptor and slow and persistently acting neurohormonal mechanism by kidney and other endocrine system, try to counter this shock or counter this bleeding related problem that I tried to present in a very simple term. So please go through the book. There must be plenty of questions because I have not covered everything. I left substantial amount of things for your study and for your discovery. So read all those things, put your question. I will be most happy to answer all those things. Thank you.